Zimbabwe, low-cost, brief psychological intervention helps people with HIV stay virally suppressed, but the friendship bench does not help people who were not already virally suppressed. Results from a study published in PLOS Global Public Health show that people with HIV and common mental disorders in Zimbabwe can benefit from a low-cost and brief psychological intervention called the friendship bench to improve their mental health outcomes and, consequently, sustain viral suppression on antiretroviral therapy. However, the intervention had no effect on viral suppression in people who were not virally suppressed at the time they joined the study. When adhered to, antiretroviral therapy leads to viral suppression, which in turn halts HIV progression into AIDS, enables a near-normal life expectancy, and prevents HIV transmission to sexual partners. However, common mental disorders, including depression and anxiety, have a negative impact on adherence to antiretroviral therapy, contributing to viral non-suppression and mortality. The friendship bench is an approach to psychological therapy that has been developed and provided in Zimbabwe, a low-income country with the fifth highest HIV prevalence globally, for over 10 years. It is a brief intervention for depression and other mental disorders, delivered by lay counselors in primary care. It employs a task-shifting approach, delegating tasks usually performed by more highly trained personnel to those with less training, such as nurses and lay counselors. This allows services to be scaled up in resource-limited settings. Just in 2023, over 2,000 lay counselors provided friendship bench therapy to over 300,000 people, with or without HIV, in Zimbabwe. Usually, friendship bench lay counselors are older community volunteers, or grandmothers, who do not have prior medical knowledge but receive training. This covers problem-solving therapy, addressing life stress issues and focusing on finding solutions to concrete problems, and simple behavioral activation, helping to develop problem-solving skills in order to tackle issues that affect the person's mood. The intervention takes place on wooden benches that are located in discrete areas near health clinics, where each attendee receives up to 6 one-to-one counseling sessions. It has been shown that the friendship bench can improve symptoms of common mental disorders and depression in adults with or without HIV attending primary care. However, whether or not it is effective in terms of viral suppression in people with HIV receiving antiretroviral therapy remain to be seen. This brought Dr. Victoria Sims from the London School of Hygiene Tropical Medicine, and colleagues from the University of Zimbabwe, King's College London and the University of Bern, Switzerland, to assess whether the friendship bench could improve viral suppression, but also common mental disorders in people living with HIV, by comparing it to usual care. The study was run in 8 primary care clinics providing HIV care and other services in high or middle-density suburbs of Harare. One limitation of the study is that it was not randomized. 6 of the clinics provided friendship bench counseling, while the other 2 served as a control arm. In these control clinics, enhanced usual care was provided by nurses and included mental health assessment, information provision, prescription of antidepressants, and referral to specialist services. HIV-positive clinic attendees could participate in the study if they had been taking an antiretroviral regimen for at least 3 months, lived in the clinic catchment area, and had a common mental disorder diagnosed. Diagnosis was based on the Shona Symptom Questionnaire, a 14-item assessment tool for these conditions developed in Zimbabwe, which includes locally accepted idioms of distress. Patients with more serious mental health challenges such as suicidal ideation, psychotic symptoms, or dementia could not join the study. At the start and the end of the study, after 6 months, clinical, sociodemographic and mental health data were collected, using 3 other internationally validated questionnaires on health, anxiety and disability. The study primary outcome was the proportion of participants not showing viral suppression, with a viral load of 400 copies or above, after 6 months of follow-up. Secondary outcomes were mental health symptoms, as assessed with questionnaires. In total, there were 700 patients in the study, 500 received friendship bench counseling and 200 received enhanced usual care. Overall, 579 participants had viral load test results available at the start, baseline, and at the end of the study, 81% in the bench arm versus 86% in the control arm, allowing for a primary outcome analysis of their data. Also, 568 participants had mental health data available at 6 months, around 81% in both arms. In the sample of 579 participants, mean age was 41 years. Most participants were female, 348, 85%, in the friendship bench arm and 127, 74%, in the enhanced usual care arm. At the start of the study, 80, 14%, participants were not virally suppressed, 14% and 13% in the bench and the control arms, respectively, which unfortunately is in line with other data from Zimbabwe. Both the duration on antiretroviral therapy and the severity of common mental diseases were similar in the two study arms. In the whole sample, prevalence of major depression and of anxiety was 56% and 47%, respectively, while that of severe depression and severe generalized anxiety disorder was also high, 12% and 23%, respectively, among 499 participants already virally suppressed at baseline. Those who attended the friendship bench clinics were 3 times less likely to see their viral load increase above 400 copies. Compared with those receiving usual care, 3% versus 9%, p equals 0.002. However, in people not virally suppressed at baseline, viral non-suppression rates did not differ between the two arms after 6 months, 54% versus 55%. The other significant result from the study is that out of all 579 participants in the cohort, those attending the friendship bench clinics were 6 times less likely to screen for a common mental health disorder at the end of the study than those attending the enhanced usual care clinics, ADED equals 21.6%, 95% CI, 36.5% to 6.7%, p equals 0.008.